I'm very happy that you are all joining us for this webinar. We're very fortunate to have with us Dr. Sam El-Ebrashi. Dr. El-Ebrashi, Sam is a dear friend and a colleague for many years. He and I have had many courses in different locations together, and we're very happy that during this period where we can't be face-to-face, we are virtually connected, and I'm happy that many of you are joining from different locations around the world to listen to Sam. Sam is a graduate of dental school and University of Newcastle, and then PROS program from University of Michigan. He is a fellow of the American College of Prosthodontists. He is a wet finger prosthodontist practicing actively, and one of the things that he practices a lot is converting patients who are edentulous into implant supported restorations. And what he's going to talk about is about the complications which many of us are experiencing. So we want to tap his wealth of information for us today to give us information about complications in complex reconstruction of implant dentistry. So please take it away, Sam.
Thank you, Homer. I appreciate you giving me an opportunity, and welcome to everybody. Like Homer said, I am a practicing prosthodontist. I don't place any implants. I don't do any surgery whatsoever. I leave that to either a periodontist or an oral surgeon that I work with. And my goal today is to share with you some of the complications that I run into. Some are fairly routine, some are not. And how do we manage these complications almost on a daily basis? I practice in Portland, Oregon, which is, for those of you outside the US, one state north of California. This is an example of a fairly catastrophic complication. So this is a patient in a provisional prosthesis. You can see here is one of the temporary cylinders. Copings are fractured, the prosthesis is fractured, and this is a difficult thing for a patient to have to deal with. And the real question is, you know, how do you help a patient maintain their sense of optimism about treatment when something like this happens? And so here's a definition of a complication: unfavorable evolution of a disease, health condition, or medical treatment. So some complications are easy to fix, some are not, and I'm going to be sharing with you both of those. Typically, a lot of what we do involves straight implants or axial implants and tilted implants. And this piece of research came out from Portugal in 2003, where they started doing immediate function, immediate placement, immediate load 17 years ago. And what they found was 93% of the 252 patients had 0 implant failures and 100% prosthesis survival. Survival is one thing, success is another. What I'd really like to know is what happened to those prostheses, how many complications were there, and how did the patient and the DDS or the BDS cope with them. So typically we're dealing with hybrid prostheses. Hybrid prostheses, essentially it's a fixed anchorage of a traditionally removable prosthesis with a different material combinations. And you can see that this appears that it has a flange the whole way, but you have to contour it in such a way that the patient is able to get in there and use superfloss to clean the cameo surface and use a water pick. Obviously the contour of the gingiva and the cameo surface has a big impact on the amount of plaque accumulation and cleansability. So if you're taking out teeth and you're reducing bone, it's very important how you suture that together so that you're not leaving a roller coaster ridge or something that has a road bump in it, because there's no way that the patient's going to be able to get the floss in, up, over, and through to the other side. So it is important that we handle the tissues appropriately. This is a patient that I treated with 2 different providers. One is Dr. Hagihat, who's a periodontist. The other one is Dr. Burstein, who's an oral surgeon. And she was treated initially for a lower fixed detachable prosthesis, acrylic titanium, against a maxillary denture. She really struggled with the upper denture, and then we ended up placing implants in the maxilla. And the main benefit of placing tilted implants, as most of you know, is better anterior-posterior spread, staying in front of the sinuses, longer implants, and you're able to get into better bone. This is the lateral piriform rim. We know this is where we have the best bone in the maxilla, approximately around the canine eminence. And in the mandible, when you have this much bone, you can go with axially placed implants. But many patients don't have this much bone. If you're lucky, you may be able to place the implants distal to the foramen. But then the question becomes, how long is your spread from number 18 to number 23? So you've got to consider flexion in the prostheses. This is a case that was done by Dr. Burstein years ago with my predecessor, and you can see in the maxilla, it's actually an upper all-on-3. This is a Filipina patient. She had teeth extracted years and years ago. I think when she was maybe 17, she came to see us with no premaxillary bone, and two options. It's either an onlay graft, trying to build the volume of the bone buccally, or in this instance, they placed the implant. It's actually, the implant is placed palatal to the nasopalatine foramen. So at a 50-degree angle, and this is kind of, I don't want to say aggressive treatment, but it's going out there on the edge. Interestingly, the cantilevers are pretty minimal. There's 11 millimeters on each side. Here is another case that was treated where we had an implant fail, and you'll be seeing this patient later, where we ended up placing a pterygoid implant. So you can use a combination of axial implants, tilted implants, cantilevers, and of course, if you want to, you can use zygoma implants. And in this instance, these implants are actually placed in the floor of the nose with a floor of the nose bone graft. I think this is very aggressive treatment. I haven't restored a zygoma case in the last 8 years. I consider bilateral sinus lifts to be possible or doable on most patients who don't have maxillary sinus pathology. And we know how sinus lifts heal. Obviously, you can have complications, bleeding, infection, and so on. But typically, those complications are a little bit easier to manage than an extra alveolar implant, something like a zygoma implant or a pterygoid implant. So is implant number the absolute determinant of success or failure? Some folks really believe that a lot of implants are required. There's a lot of dentists who feel that 4 implants isn't adequate in the maxilla. I don't think it's anything to do with the number of implants. I think it's to do with bone quantity, quality, and patient factors. So if a patient's a heavy smoker and an out-of-control diabetic, I don't think that's a great candidate for implant surgery. And of course, this sadly is the type of thing that's happening. I see a lot of patients who have had treatment by other providers who come to see me and say, I can't wear my prostheses. And I don't consider mini implants to be long-term treatment. I consider mini implants to be provisional treatment or temporary anchorage devices for ortho, but I wouldn't do this on a patient. Here's this patient pre-op, and this is how she presented to me. She actually had another 3 or 4 maxillary implants that failed. And you can see there's a little bit of divergence, but he's done a reasonably decent job getting things parallel. The problem with this patient is she has an extremely dry mouth. She has polymyalgia. She takes pain medications, and any tissue-supported prostheses is really not going to work. Here she is in the mandible, and again, we've got extreme divergence. How can you get a prosthesis that's got a passive path of insertion that's not going to engage the undercuts to actually be successful in a patient like this? And you can see the amount of recession that she's had in the mandible. Not surprising, this case actually went to litigation. So, no clever arrangement of bad eggs ever made a good omelet, C.S. Lewis. Let's talk a little bit about the literature. This is a paper that came out from Boston with Papas Piraticos and his group in 2019. This was a retrospective study, and they looked at 19 patients that were fully edentulous that were treated with a maxillary and mandibular all-on-4 prosthesis. And they looked at complications. So they had 2 out of 249 implants that failed. So that's a very high implant survival, 99.2, and then the prosthesis survival was 92.1. And the question is, if 2 implants fail in a patient, can you make it work? Or if an implant fails in a distal cantilever. So implant failure is an issue. At the 5-year post-op, the most frequent minor biological complication was soft tissue recession. Most frequent major biologic complication was peri-implantitis. Most frequent minor technical complications, prosthetic material wear. And the major technical complication was fractured prosthetic material, and these were acrylic titanium. The 5-year rate for a prosthesis free of biologic complications is 51%. That's alarming, because that means that 49% of these cases had a biologic complication. My experience tells me that biologic complications occur at a much lower incidence than mechanical complications or material complications. So the 5-year rate for prosthesis free of technical complications is around 57%. So 43 out of 100 had a technical complication. So let's look at some of those complications. This is what we call peri-implant mucositis. Reversible inflammation affecting the peri-implant soft tissues. This is all related to contour of the prosthesis, and you can see this white cake material, that's calculus or plaque. Here it is with the bridge removed. And now you have a look at it, you can see on the undersurface of the bar, the patient's done a pretty poor job. So it is very important that patients clean using superfloss. And then peri-implant mucositis can progress to peri-implantitis if calculus is not removed. Here is a patient that's having a fixed detachable upper prosthesis. And when we came to do the try-in, you can see we've got some soft tissue recession and the transition line is very high. Now, fortunately for us, we had enough room to actually move everything up and cover these are the abutments, not the implants, giving her an appearance like that. So if you have abutment configuration that's too facial or keratinized mucosa that's gone, you may have an issue. 45% of patients have peri-implant recession. I don't see that in my practice. I would say it's in the 5 to 10% range, and I think it's related to a lack of keratinized mucosa, implant positioning being too facial, or abutment position too facial, and patient biotype. And I do feel that biotype has something to do with incidence of recession and incidence of inflammation. Here is a patient with real peri-implantitis. You can see she's lost some bone here. Interestingly, there's the nerve. She's got some calculus there. And you can see there's been some exposure of the implant threads. That's a very difficult area to clean. 10% of patients. This may be related to biological factors, the implant itself and the soft tissues, and the prosthetic contour. But really what it has a lot to do with is accessibility and hygiene. So if you have a patient with a thin biotype, and this patient did, she's more predisposed to recession. And just because I have peri-implant mucosa the day of surgery does not mean that I'm going to have that mucosa a year or two later. What about wear? This is a 10-year post-op on a patient who's an extreme bruxer. You can see acrylic in this type of occlusion really hasn't worked very well. He's protruding, and you can see the significant wear and not good oral hygiene. So acrylic for me is a poor long-term material. The only prosthesis that I'm restoring with acrylic now is a mandibular fixed detachable hybrid, acrylic teeth, titanium bar against a maxillary complete denture, trying to avoid acrylic as much as possible. The prosthetic material wear was 49%, and that may be due to patient factors, poor cross-linking of the acrylic, and opposing occlusion. What about prosthesis fracture? Here is the same patient, and you can see here we have fracture. This prosthesis was made by my predecessor, and you can see in this instance they've got second molar cantilever. This makes no sense. I don't think you need to extend your prosthesis as far back as second molars. My treatment protocol is first molar to first molar. So I explain in a lot of detail that a patient is going to get 12 teeth. You can see there's a multifactorial etiology, and it may be patient and parafunction dependent. The majority of my complications are in a minority of my patients. I call it the 80-20 rule. I have probably 80% of my complications in 20% of folks. They tend to be men, they tend to be non-compliant, and they don't wear any kind of occlusal device or nocturnal device. So what's the weakest link? Well, occlusal overload and implant prosthesis can cause mechanical failures, which can cause bone resorption before the prosthesis fails, or if you're lucky, the plastic teeth wear out before you get bone resorption and or implant failure. So here is a patient. He's a nurse. You can see he's got impacted wisdom teeth. He's in his 40s, from Romania, pack and a half a day smoker. 10 years later, he comes back and he has pus coming out of this pocket. You can see that implant has failed. So what did we do for this patient? We actually took a CT scan with the prostheses off, and we ended up removing the bridge, taking out the implant, placing another implant here, another implant there, putting the same bridge back on, letting it heal, and then I'm making a new prosthesis for him. But it is definitely related to smoking and or poor oral hygiene. So patient factors definitely have a part to play into the success or failure of a prosthesis. I very much believe that. And some of those are out of our control. Whew, look at this complication. So this is a patient who's on bisphosphonates, and they ended up having a upper and lower all-on-4 done in St. Louis. She developed bisphosphonate-related osteonecrosis of the jaws and osteomyelitis, and obviously needed to have a significant surgical procedure. So what role does the provider play when it comes to failure? Would a CTX test have been helpful for this patient? Is this a patient just a poor candidate for implant surgery? Could there have been another way around it? And obviously when you have this type of complication, I don't want to say it's irrevocable, but it's pretty significant. And then some of our complications are related to lack of knowledge or lack of familiarity and lack of communication. So this is a patient that had 5 axially placed implants, straight up and down. Implant surgery was great, but the prosthesis was poorly made. And if you look carefully, you can see the prosthesis is fractured, and this is a removable prosthesis. And when I remove the prosthesis, we can see it's poorly fitting. That's calculus. And we can see we've got multiple prosthetic screws that are fractured. So here's the implant, straight up and down. There's a transmucosal element or an abutment that's coming through. In this instance, they're straight. And then you have the prosthetic screw, which is fractured inside of the abutment screw. So here is an abutment screw without a prosthetic screw fracture, and there's what that looks like. In this instance, it makes no sense to use the same abutments. You remove the abutments, you clean everything up, you start over with new abutments. So what role does the laboratory play into the success or failure of the prosthesis? Significant. Because if you think about it, once the surgery's been done, that's that. The implants are either successful or not, and you have to restore them in the position they're in. A lot of patients don't like to hear after they've had surgery, well, this implant needs to be put to sleep or I can't use this implant. So that can be an uncomfortable situation. And so let's look at another paper that came out from Purcell from Ohio State with Ed McGlumpy, and they looked at prosthetic complications in lower acrylic titanium fixed prostheses against maxillary complete dentures. Okay? What they found was over time, below 2 years, you really didn't have a whole lot of need to replace the teeth. The maxillary denture reline with time, obviously when you have a fixed prosthesis in one arch, removable in the other, you're going to get rocking and movement of the maxillary prostheses. And interestingly, what I'd like here is that they started off with some temporomandibular symptoms, and then with time, the patient adapted or habituated, and they went away. Now, when we look at abutment screw loosening, they had some screw loosening. Typically, you don't see that with abutment screws because abutment screws are pretty sturdy and they're typically torqued to 20 newtons. They're big. Abutment screw fracture is something that I've seen very rarely. It's happened twice. And the retaining screw loosening or complication type, that can happen if you have multiple prosthetic screws that are getting loose. That tells you that you have a problem. And that problem can be prosthetic overload. So if you're breaking things routinely, it means your occlusion is off or your prosthesis is misfitting or a combination of the two. And so they found there was no framework or abutment fractures. The most common complications were replacement of posterior teeth due to wear, need for upper denture reline, fractured resin anterior prosthetic teeth. Most of the fractures we see are anterior teeth because of the shear forces. Posterior teeth tend to wear. Also, your bite forces posteriorly are more vertical. They're compressive. Anteriorly, they're shear and they're popping off. The analysis revealed that a patient is 8 likely 8 times more likely to have a screw complication after 5 years, 8 times more likely to need a hard reline after 5 years, and 52 times more likely to need posterior tooth replacement after 5 years. So we know that acrylic teeth wear out. That's a given. This is the typical patient. This case was done in Las Vegas. Inadequate ostectomy, poor contours, inability to clean. You can see the opposing occlusion. You can see the fracture. And the question is, who's paying the ultimate price for poorly performed surgery? It's both the patient and the prosthodontist. Because as far as they're concerned, the implants are integrated. But if inadequate bone reduction has been done, you're paying that price. And if I made a mistake in my career, and I made many, in the beginning, I didn't ask for enough bone reduction. So then I made prostheses that really were hard to maintain, or I used acrylic in a situation where there wasn't enough room. In this instance, perhaps crown and bridge would have been better. So what about reversible complications with acrylic? Sometimes you can have cohesive failure, adhesive failure, and you can see here there's been cross-contamination between the titanium bar, the opaquer, and the acrylic. There's a lot of interfaces that can become contaminated. In this case, this is an upper all-on-5 with a long cantilever on the left side. Here is a situation where perhaps there wasn't adequate room for the maxillary cuspid, so the titanium bar may have been too bulky. This is the patient you saw earlier on with the axial implants in the mandible and the tilted implants in the maxilla. Look at the amount of wear she's exhibiting on her teeth. Rare that you see multiple fractures in a female patient, but it can happen. So I don't look at gender per se. I look at what I call serial fracturers, or folks who are constantly on the schedule telling me that either their nocturnal bruxism is an issue, or perhaps they are somebody who's unaware of daily clenching. So you have composite shear and tensile stresses. This is a dissimilar material. You can see the opaquer popped off, the acrylic popped off, and the titanium's exposed. What about flasking? Well, when we flask something, there's a boil out where you have the teeth on one half of the flask, you have the titanium bar on the other, you sandwich the two together, and you inject the acrylic in the middle. If there's any contamination here, you don't get a good bond of the acrylic to the titanium. And if there's contamination on the teeth, if they haven't been boiled out properly, you don't have a good acrylic bond between the teeth and the actual polymethyl methacrylate. And we can see here we've tried to put some diatoric support. This should have been done better. There should be more diatoric support to try and get the acrylic to actually lock in almost like a pulp chamber. So poor processing gives you inadequate tooth bond. And then, of course, poor design. Look at this titanium frame design. This is basically like an ice rink or a hockey rink. And you can see the prosthesis is failed catastrophically. I got this from a lab that I no longer work with. The patient called me from Bend. He said, my teeth broke and the prosthesis, or the bridge is still intact. I said, what do you mean? He said, well, the teeth are in my hand and the titanium bar is still in my mouth. So he came in and that's what it looked like. So mishandling of the opaque layer and poor design. If you look right here, this is actually last night in Portland. This is Mount St. Helens. This is on a bike ride that I took. Mechanical complications. Here is another case where you have a naked mandibular prosthesis where you can see there's no diatoric support for the acrylic. And in this instance, it's a misfitting bar as well. So by this point, I'm no longer working with this lab. And so this is a CAD-CAM process where prosthetic fit's very important. And what we don't really honestly know is what are the consequences of poor fit on prosthetic screws and the prosthesis. Typically, when something doesn't fit well, you got to torque it in and you're going to be putting things under stress. When you put things under stress, you can cause a lot of strain on them. And if it's strained beyond its limit of elasticity, you end up getting fracture. So this is a dense ply case, an old lower all-on-3, where the patient came in, he's an ectodermal dysplasia patient, and he had a fractured screw. And so when you have a look at the case, AP spread is minimal. There's the anterior, there's the posterior implant. Cantilever should really be AP spread times by 1.5. In this instance, I violated it. I went 26 millimeters on one side, 20 on the other. He had a removable opposing prosthesis. So I figured with something removable, his occlusal forces weren't that high. I was wrong, because he fractured the screw. Here it is. You can see it in the uni abutment. My mistake here was not putting on uni abutment, healing abutments pretty much straight away. Soft tissues don't look great. Here is me using a cow horn to remove, and here's the screw actually being backed out. Here's my PA to verify that the screw is out. I would rather use something like a cow horn versus a high-speed handpiece for two reasons. Firstly, I don't want to damage the abutment. Second, obviously nowadays, you'd be pretty nervous of any kind of aerosol or anything like that. So if you can use something non-rotary to remove a screw, the likelihood of you damaging an abutment or an implant is much less. There's the prostheses. There's the cantilever on the left side. The right side, there was an additional tooth. So it was a canine and 3 premolars, and I cut it down. We decided that from a safety standpoint, making something removable would be better. So still use the same 3 implants. Here's a screenshot of a prosthesis that's fixed detachable, allowing the patient to pop in with his thumbs and unlock the latch and remove the prosthesis. So this is Naguib Mahfouz. Naguib Mahfouz was an Egyptian Nobel laureate, the only one from Egypt. And I thought this was a very appropriate quote for everything that we're going through today. Fear does not prevent death, it prevents life. We've got to be careful in terms of sort of getting so anxious or so afraid of the situation that we're in, because we've been in similar situations like this before. When the HIV epidemic came out, we were all very concerned. Somehow we figured it out. Let's get back to it. Framework design. It's important that you have a convergent path of insertion. Here is a view. You can see diatoric support on the occlusal surface and on the lingual surface, and on the facial surface, we've got some rolling in and out to support the teeth. Before you design your framework, you have to do a full contour wax try-in. You then make a putty matrix, and everything is scanned. So now when they come to design your framework, it's an optimum support for the veneer material. Just like the old days when we used to wax a full contour wax up for a 3-unit FPD, cut it back, knowing that we had optimum support of the metal for the porcelain. So how do we optimize it? Very, very important that we have as much rigidity as we can possibly get, and we want at least a 4x4 or 4x5 contour. This has to be hygiene friendly. If you're working with a lab, they should be sending you screenshots for you to understand the contour and the cantilever length and so on. Here is a different patient who had his teeth taken out in around 1942. This is Leroy. Leroy was a World War II vet. He came to see me in his 90s, and he said, I can't wear my lower denture anymore. And I said, what's going on? He said, he just won't stay in place. Of course, he had significant mandibular atrophy. In this instance, there's no bone reduction done. The patient already did that for us. You can see there's ample bulk for the prostheses. Again, lots of diatoric support for acrylic retention. Here is the same patient with the opaca, and you can see you've got diatoric support on the lingual and on the occlusal. Here is the amount of room for the teeth. And again, there's the prosthesis in situ. No complications at 5 years. Typically, when you have a fixed prosthesis against a maxillary removal prosthesis, the complication rate can be fairly low. What happens if you have complications that are not taken care of? This is a patient 10 years post-op, prosthetic screws got loose, abutments screws got loose, abutments became loose, and now we started to have some rocking and back and forth, and ended up getting with marginal bone loss and a prosthesis that fractured. So the anterior implants fractured, and the whole prosthetic, the post number 29, the whole implant failed. And this is all micro motion, or in her instance, macro motion. Those implants have to be removed. She has to wear a complete denture. We got a graft. She fractured 3 of the 4. This fractured, that fractured, and this whole implant failed. So the bone fractured here, but both of these implants have failed. And maybe this is to do with the implant topography. I don't think so. I think this is related to micromotion. And here is another case where a patient had a loose prosthesis, didn't do anything about it. You ended up getting rocking back and forth. And in this instance, she actually fractured the abutment screw. So there's the abutment screw that's fractured. A portion of it's inside the implant. You can see she's fractured part of the hex off the implant. Limited bone, fairly superficial nerve. The patient has leukemia, diabetes, and a smoker. And we elected to leave that implant alone, not even remove it. So I cut the bridge. I left the implant as is. You can see this is now covered in soft tissue. And the reason we did that is myself, the surgeon, and the patient were concerned about surgical complications. Also, her life expectancy was fairly limited. She's still around. This is about 3 years ago. Titanium bar fracture. If a titanium bar is poorly made, it will fail with time, and it's fatigue failure. The mechanism is repeated loading. It's what I call the diving board. You stand at the end, it flexes, it flexes, it flexes. And this is a patient who called me and said, I was chewing and I heard a pop. Here you can see the fracture. Look at the amount of room there is for the bar, and the bar was poorly fabricated. So here it is. Always the fracture tends to be through the weakest portion, and that's right through the cylinder. So if we look at a different patient, actually, let me come back to this. So fractured titanium frames. In the old days, we used to make pure titanium. Nowadays, we're using titanium, aluminum, a vanadium alloy, which is much more resilient, and we're much more aware of thickness. We want a 4 by 5 millimeter cross-section if possible. Here is another patient who's a farmer in Tillamook. This is his provisional prosthesis. Final prosthesis was delivered in 2014, I believe, which was 2 years post-op. Here he is, he fractured it. So you could have placed a short implant back here. The problem about trying to place a short implant back here is you don't have a lot of vertical height. So as much as it's tempting to place 6 implants, the real question is, where are you from a neurological standpoint? And how much vertical room do you have for your prosthesis? So here it is. You can see here's a pretty significant bruxa. There's the fracture. It's always through this point. Here's the coping, here's the cylinder, or where it emerges. That's the weakest portion. Made him a new prosthesis with a much bigger cross-section. He's complication-free at 5 years. So people ask me, are you an expert? And I always laugh, because this is my definition of an expert, or Neil, I like this definition. An expert is a person who made all the mistakes possible in a narrow field. Is zirconia the answer? I think zirconia gives us a little bit more peace of mind. I've probably restored, I don't know, maybe 300-400 zirconia arches. So far, we've fractured 2. And I think it's all related to mishandling or misfiring. Zirconia has some parameters that you have to work with. The milling parameters has to be a certain thickness. And you can see in this instance, this is a screenshot from somewhere else where they used 1 premolar and 2 molars. So it's a much more rigid material. It's not a very forgiving material. So this is the prosthesis that I delivered. Patient came in a month later, and I said to him, "What did something happen?" He said, "You know what? I yawned and I heard a loud pop." And it was with the prosthesis fracture. And of course, like all maxillary dentures, where do they fracture? Right down the midline. You got to consider the maxilla it's a piece of bone, and bone has flexibility. So you need something that has some give to it, some toughness to it. You can't have something that is so stiff that it has no resilience whatsoever. So it's very important that you're using verification jigs. Some of my colleagues are actually splinting across the arch. The way we do it is we actually fabricate a prosthesis with individual copings and GC pattern resin, and then we connect them intraorally. In this instance, you can see this has been crisscrossed with superfloss. Doesn't matter what you do, you got to verify your cast. So it can be metal supported, pattern supported, acrylic supported, or stone. There's a fellow called Michael Wise in London. He's no longer practicing. He used to verify this with plaster because it had very, very little give. And zirconia prostheses are extremely radiopaque. So it's good and it's bad. And sadly, this next slide was sent to me by a periodontist And she said to me, this patient has significant peri-implant infection. I said, excuse me? She said, if you look at the palatal, I said, you've got some artifact on this. She said, no, no, no. So in fact, really, you shouldn't be taking any panoramic x-rays or CT scans with any final prosthesis. Periapical radiographs are the way to go. And the reason is you got a lot of beam hardening, what we call photon starvation, and scatter when you're taking extra-oral radiographs. So periapical radiographs are absolutely the way to go in terms of looking at peri-implant bone loss. If in doubt, remove the prosthesis and probe. This is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. My patients that I treat are extremely complex. I see a lot of patients with many morbidities. This is a patient called Sean. She's coming in for an upper all-on-4. She's age 77. She's 5'5". She's 153 pounds. She's allergic to all of these drugs. And this is what she has: xerostomia, hypothyroidism, hyperparathyroidism, high cholesterol, hypertension, stage 3 kidney or renal disease, gouty arthropathy, arthritis, tinnitus, constipation, back, neck pain, headaches, lymphadenopathy, anxiety, depression, insomnia, reflux, GERD, hyperlipidemia, osteoporosis, alcohol use, irritable bowel syndrome, history of cancer, radiation, obsessive compulsive disorder, and these are the medications she's taking. And if you look here, it says no gun, hat, or bob tie. Pretty demanding patient. And so when we look at this piece of research that came out last year, interestingly from this article, I'm not really looking at the 10 to 18 year follow-up. I'm looking at the incidence of systemic disease correlation with failure. Cumulative survival rate of the prosthesis was 98.8. Implants were 93.0. Mandibular cases. Smoking and previous implant failures are indicators of biological complications of marginal bone loss more than 3 millimeters. If a patient had a biological complication, it is associated with implant failure. So if you have a patient who's got chronic periodontitis, they may not be a great patient in the long run. Incidence of mechanical complications was 37% in male patients. Prosthetic material is significantly associated with failure. Acrylic, more so than metal acrylic, more so than PFM, and at this point they were not looking at zirconia. And the interesting thing about this is if you look at a compromised patient, healthy versus systemic. So this is a healthy patient. Here is a compromised patient. At 120 months, approximately here, 94% CSR, 98%, 4% difference. And then when you get to this point here, it drops further. So if you have a medically compromised patient, whether they're taking a proton pump inhibitor or whether they're taking some kind of SSRI, selective serotonin reuptake inhibitor, that can affect bone turnover late, and their PPIs can affect calcium absorption. So there's a 65% increase in odds of a biological complication in a patient with a systemic condition. So this is John. John is a retired Army engineer. John was a smoker. He has this little knot on his lip. I'm always concerned about that, and he always reassures me. That's been there for a long time. He smoked a cigarette facing inwards when he was young, and he's had this burn there for a long time. So John is a typical patient who's getting up there. He's retiring. He's now living in Arizona. And he said, I really don't want dentures. I've heard lower dentures are awful. I think I can tolerate an upper denture. How about we do something removable on the top and something fixed on the bottom? I said, sounds great. That's what we did. Lasted about a month before he came back and said, listen, I can't tolerate this upper thing. Do I have enough bone to place implants on the top? So we did that. There they are. And interestingly, we actually used a straight abutment here, trying to improve the AP spread. If you use an angled abutment, 30-degree angled abutment on this, you're going to end up with a longer cantilever. So I used a straight abutment, which made it a little bit difficult. Here is the titanium bar triumph. This remained symptomatic. And you can see now, before I got to the final prosthesis, I switched it to an angled abutment because I was divergent with my provisional prosthesis. At this point, he's still symptomatic. We decided not to finish the treatment. What did we do? I said to him, I don't think this implant's doing very well. We ended up removing the implant, processed the upper as an all-on-3, with the titanium, cut it around distal to the canine, removed that implant and grafted it, waited, came back, placed an implant in the tuberosity region, implant in number 5, did not load them, let them be, and then eventually restored them as an all-on-4. I said to him, John, why do you think that one side has failed more than the other? Or what? He said, basically, I do all my chewing on the right side. So education is the path from cocky ignorance to miserable uncertainty. Let's talk about something that really isn't talked about very much, which is surgical experience, both in medicine and dentistry, workload and learning curve. This is a review paper that came out of the European Journal of Oral Implantology. And they found in this particular review by G et al., immediate loading of 50 maxillary mandibular hybrids, failure was associated with experience. If you had less than 5 years, your failure rate was 12.2%. More than 5 years, your failure rate went down by a factor of 5. And in medicine, it's a similar story. There's a learning curve. 8 out of 12 studies found high versus low volume surgeons are more experienced. Their patients had higher morbidity and mortality. Makes sense. All surgical learning curve studies agreed. The more procedures done by an MD or a DDS, the better the outcome. I think we all know that inherently. And when somebody gets a little bit out of their depth, this is what happens. This is a patient that was treated by a GP. They did a lower all-on-4. They nicked the lingual cortex, lingual artery. Patient started to asphyxiate, and the dentist was smart enough to realize what was happening. That he didn't intubate the patient, but he drove her to the hospital where they intubated her. And this is not the patient protruding the tongue. This is basically Ludwig's angina, where you have blood accumulation or an infection in the floor of the mouth, and now you're having a problem with the airway. So here, when you see the outline of the tongue relative to the denture, here is one of the blood clots that was removed. So if you're going to be doing surgery, you need to know how to deal with the complications. This can be life-threatening. So a human factor is the primary cause of complications in implant dentistry. I think it's a valid question. Patient factors for sure. Some of it is us. We tend to practice using a heuristic model where we sort of use pattern recognition or the best educated guess that we can versus strict evidence. Your responsibilities in practice are 2. Do no harm and act in your patient's best interest. Non-maleficence and beneficence. So if the question I always have for folks or my students, if you would do it for your parent, then it's okay, treatment for a patient. You got to do a risk versus benefit analysis from a patient standpoint, not your standpoint, and informed consent may not be universal. So complications are often analyzed from a technical standpoint, not from a patient perspective. This is a paper by Haynes, and there's a book by Atul Gawande called The Checklist Manifesto. It's an excellent book where they looked at rates of complications in hospitals where people just started to wash their hands, soap and water. What happened to the mortality of patients? And just by using checklist, mortality went down by 50%. Complications went from 10.5% to 7.1%, 30% reduction. Here is an abutment screw with a fracture prosthetic screw because somebody decided to torque that to 35 Newton centimeters. The abutment screw needs to be torqued to 35 Newton centimeters, not the prosthetic screw. And then here is a patient who's had 2 prosthetic screws placed on top of each other. That's just being in a rush, what I call cognitive overload. If you can't focus on the task at hand, then something's going to go wrong. So in conclusion, you got to give patients autonomy and self-determination as your guiding principles. Help them. Help them make decisions that are complex or subjective, and give them time. Maybe you put off treatment for a while, let the patient think about it, or even better, have the patient call an existing patient or a patient who's had treatment and have them ask, would you have this done? Was it painful? What did you like about it? What went wrong with it? That's a very powerful tool that I use. Beneficence and maleficence are important. Non-maleficence, sorry. You got to disclose everything that can go wrong to a patient. Make help them make the right decisions. You got to be honest, give them veracity, and give them accurate and objective information in a manner that helps your patients, not hinders them. And research shows there's no established link between willingness to disclose an error and a risk of litigation. Patients like to be heard. So patients know when something went wrong. What we're trying to do is avoid a poor outcome prior to that happening and discussing that before it ever happens. These are my two kids. This is in Bend last year after a 100-mile bike ride. I broke my leg in January of 2019, and I always do a cancer ride in honor of my parents who both passed from cancer. And my daughter Sophia, this is Zane. She insists that the following: we do hope that he didn't put you to sleep. Thank you very much for your time.
Yay. Thank you very much. I really appreciate Sam for a really informative presentation. And I think the topic of complication is something that we certainly learn a lot from, because most of the time when you're discussing cases, many would love to show their heroic work rather than the complication. But I've personally learned a lot more from my mistakes than from the successes.
Agreed, Homer.
So there are, you know, in addition to some of the positive responses, there are some questions that are coming in.
Yeah.
Any of you have questions for Dr. El-Ebrashi, you can use the Q&A, you know, panel below to submit your questions. I have a couple of questions. We have, in terms of the material selection,
yeah,
there are, you mentioned that you wouldn't, you know, use acrylic, metal acrylic as much today.
Yes.
Have you found that if we're using denture teeth as a hybrid versus using the milled PMMA or other types of, you know, nano composites and others, is there any difference?
There is, Homer. So the denture teeth, so the case with the advanced wear, the 10-year post-op that I showed you, that was old denture teeth. So nano composites are better, and milled PMMA is definitely a stronger material. So acrylic is definitely progressing and evolving. It is, after all, acrylic at the end of the day. And when you talk to a patient about their chewing ability with acrylic compared to something that's stronger, whether it's PFM or zirconia, they will tell you that they can't crush the food. And there's been studies where they did a sieve experiment where they took some peanuts, patients chewed them for a while, spat them out, and they saw the efficiency of the teeth. So acrylic teeth absorb a lot of stress, but they don't allow the patients to really masticate the food thoroughly. So I like to use acrylic and titanium when my opposing occlusion is acrylic. It makes no sense to use zirconia against acrylic, although I do know a couple of people who do that. For me, that doesn't make any sense. The disadvantage of zirconia against zirconia is the clicking. And so in the old days when we used to use porcelain teeth on dentures, it was a similar story. So all these materials have advantages and disadvantages. Definitely nano-filled composites are better than just old acrylic teeth or poorly cross-linked PMMA. And milled is better than what we had before, but it is acrylic. And so, you know, if you have a patient, where I use acrylic is when somebody's had a denture for a long time and they're comfortable. Where I don't use acrylic is when a patient is young and they're expecting something that's much more resilient and tough.
How about the choice of the bar? Have you found any difference between using titanium versus chrome cobalt?
That's a really good question, Homer. I have not used chrome cobalt. I've been using titanium for years. I use CAD-CAM titanium. I've been using CAD-CAM titanium since 1995. My bar fracture rate is less than 0.5%. And typically when a bar fractures, it's because it's poorly designed or the cantilever is too long. So I do think that cobalt chrome is a possibility. And I think I have friends who have used it with Crown and Bridge and so on. But it's really to do with the design of the bar and the support for the superstructure, whatever that is, whether it's PFM, whether they're individually cemented crowns on a Malo bar where you have a titanium bar, 12 individual copings and you're cementing crowns. It's all to do with the interface and the interaction between the weaker material, which is the veneer. It could be porcelain, it could be acrylic, and the substructure. Do you have any experience with cobalt chrome?
I have had a limited number, but definitely these were recommended by, in cases where there was less of a prosthetic space.
Yeah,
now,
I agree with you.
related to that, there was an open question from Dr. Safa Tahmasebi, who asked, what are your guidelines from prosthetic space when using metal acrylic versus zirconia?
Good question. So metal acrylic, we like to have at least 15 millimeters from the incisal edge to the head of the implant. And I call that rule the 4-5-6 rule. I want 4 millimeters to allow me to get my abutment on and what I call transmucosal space so the patient can clean underneath. I'd like my bar to be at least 5 millimeters occlusally, apicoronally, and I want some width. If I can get a bar that's 5 by 5 cross section, that's very resilient. And then obviously you need prosthetic space. So 15 millimeters for acrylic titanium. And I think with zirconia, there's no long-term research that talks about actually measurements, but you can probably get away with 12, 13. It all depends on the contour of the prosthesis. If you're going to have a prosthetic gingiva, then you need more room. So if you think of an upper central, that's 11 millimeters. So if you are making an ovate, pontic, tissue-borne, no prosthetic gingiva, you don't need to do a lot of bone reduction. But that's complicated prosthetics because shaping the shape of the pontic into the sockets and so on is very complex, and Gallucci talks about that. And your transition line, or lack thereof, in that instance works well. So if you have inadequate vertical space, if you have inadequate, Homer, can we go back to sharing?
Yeah, you can go ahead and share. Actually, we see it. You are in shared mode. You can go ahead and post whatever slide that you like.
Yeah, I'm trying to. Okay, so let me pull you up this case. It's actually one that I didn't show, done by a GP in Bend, in the maxilla, 6 implants placed, no bone reduction, high smile line, transition is visible, acrylic or wax is visible. In that instance, she's not smiling too high. You can see this is poorly done. Here are the prostheses, no multi-unit abutments. So he's going straight to the fixture level, which is going to be extremely difficult, and no bone reduction. So I said to him, this has to be a crown and bridge case. What he was proposing to do was reduce bone between the implants. I'm like, no. You just close down the vertical dimension, do it as crown and bridge. I referred him to a lab technician. So here is a provisional prosthesis that's cement retained. And you can see there's been some recession, but she's looking much better. She's still a little long in the tooth, but better.
I think, yeah.
So in these instances, go ahead, Homer.
No. Yeah, I was just going to comment, because if you don't mind going to the case where you had the integrity of that prosthesis shown, the same before, I just want to ask a question, because when you show the
right here,
one. So many I've seen some try to correct this problem of inadequate resection by creating that ridge lap, by raising that flange up.
Yeah.
And that may not be the best solution, because that's going to create almost a impossible area for patients.
It's a food trap
all the time.
I agree with you. It's an absolute food trap. So you have to be able to contour the tissues. This is our protocol. On the day of surgery, when we do the bone reduction, I come and check bone reduction. then the surgeon's placing his abutments. I'm checking the abutments before they're torqued into place. He's suturing everything shut. Then when I come to make my conversion, my lab techs are actually taking a straight handpiece and they're adjusting the moulage on the cast to flatten it out, because we know the patient is numb that day and we can actually exert some pressure on there to try and get as flat a surface as possible. So this is not a case that I restored. This was a case that was done by a GP. This is his first and only hybrid that he ever did. He said, never again. I said, it's not easy. So the bone reduction is very important. Suturing is absolutely important. And creating enough room for the prostheses, taking into account the patient's smile line, is perhaps the most important piece of it. Because if the smile line is like this, then you have a problem. Right?
That's right. Well, as a periodontist, I could tell you that personally, it was completely counterintuitive for me to cut bone. I
understand that.
To find every instinct in my body to go ahead and cut bone. So I've made a lot of mistake in the beginning, not resecting adequate bone, and exactly we paid the price in those cases because there's nothing you could do to correct it afterward. But my question
I'm still repairing prostheses from 2006 where there was inadequate bone reduction. I see the patient's name on the schedule and I know exactly what's broken because there was no bone reduction, and I tried to restore it as a hybrid.
So how do you communicate the degree of reduction needed from you, from your prosthetic standpoint, to the surgeon?
Really good question. So what we do is we make a surgical guide that is a duplicate of the prostheses with a window. I don't have it in my slides, but let me see. Do you mind if I try and pull something up?
Go for it.
So what we do is we make a duplicate of the prostheses, and there's a window to show the amount of reduction. And there's a trough on the lingual to show where the abutments are. So I'm hoping that it's in here. And then I actually check the bone reduction live during the surgery to check to see how much reduction there is. Also, in a high smile case, I am taking a photo and it's getting printed and it's being put in the OR so the surgeon has an understanding of the patient's high smile, because once they're numb, it's too late. I don't have the picture in there, but it's basically a clear copy of the prostheses with a window cut. I'll send you a picture of it. You can put it on your, it has a black line in the Sharpie that shows where the bone reduction needs to be. Right.
So just a thermoplastic template.
It's a copy of the denture. It's an acrylic copy that has been processed. It's a duplicate of the prostheses, but with thermoplastic acrylic. It's fast. It's cheap, but we use that for all our cases. Let me see if I have one here.
So it's resting using the palate as a
correct
as a basic reference for seating.
Correct. You know what? I think I found it. Here we go. Let me pull up these pictures. So the palate, in the mandible, it's important that you extend it as far back as the retromolar pad, because what's going to happen is the case is going to be flapped and it's going to be fitting pretty loose. So they're not very accurate, but you definitely need them. So here is a patient, and this should show bone reduction. Where is he? Here it is. So this is a patient that had 2 maxillary implants. If you can believe it, they're 5mm implants. Don't ask me why. That were placed in a lateral and a canine. Here is us planning our case after doing a wax try-in. And you will see the surgical guide shortly. Sorry, these are a little out of sequence. So there's the bone reduction after he's removed the 2 implants. There it is, Homer. Can you see it?
You can actually just put it in presentation mode so it will show up.
Presentation mode.
On your, yeah. Just double click on the slide so you can show.
Are you seeing it now?
But we are seeing the light box view of your slides. So if you just put it on presentation mode, if you double click on it, no, you have to, you stop sharing your slides. So go ahead and
hold on.
Share your slide one more time. There you go.
So that's after the implant's been removed. Sorry, this is the wrong sequence. Here it is. Now we're checking where that window's been cut.
Right.
And there's also a lingual window which shows where the abutments are. And this is before he sutures for me to check. So this is where the old implants were. They've been removed. There's 2 straight abutments here and 30 degrees on the back. There's the emergence profile. So I use a duplicate denture in clear acrylic with some markings on the facial. That's typically 16 millimeters. And there's a trough on the lingual so we can put it in and look occlusally. And I'm sorry I don't have a picture of that, but you could put that in and you can see where the abutments are, and you want the abutments to be emerging around the cingulum.
Got it.
Good question.
So, you know, now many are pushing the digital workflow.
Yeah.
And if you were to utilize the digital workflow, have you found any benefits in terms of making a converted prosthesis versus having a digitally fabricated prosthesis that, you know, have you found that to save you any time during the immediate loading?
In a word, no, because it's basically a similar thing. So this is what I was talking about in terms of the lingual channel.
Right.
And with our digital cases, it really has not made a great deal of difference. If anything, there's some teething problems with a digital case, because if you're applying composite, that can be challenging. And so here's my first digital case. And I'll show you the final prosthesis. So here's planning. Can you see that?
Yes.
So that's the screenshot. Those are the shots that are sent to me. That's a plan, occlusion, overjet, overbite, all the stuff that I get sent. Here is a milled surgical guide. You can see the markings. Here is the actual prosthesis that's sent. There's the occlusal registration that's rigid material. Here is my pickup. Now you can see on the cast, you can see where the suture lines are, how we're smoothing that down, Homer. This is what I was talking about earlier on. See how that bump is there? How I've smoothed it down? Now enabling the prosthesis to put some pressure on the tissue. Here is applying the gradia. Take some time, and there's the prosthesis. So I think it's a tool. I don't think it is. The material is a better material. I like the material. I like milled PMMA. There's no doubt about that. And it allows me to plan my cases digitally. I can communicate with my lab much easier. But like anything, there's some learning pains.
Personally, I've worked with some really experienced prosthetologists in the digital workflow, and I found that many times when these are fully digitally produced, they could be so far off. That,
you know, I think, put it this way: if I have a challenging patient with a high smile line, I'm not doing it digitally. I'm doing analog. My lab is setting the teeth. I'm sending them pictures. I'm still not confident enough with the full digital workflow. You know, once I've done 100 cases, then I'll feel more comfortable. I've probably done about 30.
I believe that many, you know, presenters are not being fully transparent about these. They kind of brush over the issues and they present it as if there's absolutely perfect fit every single time. So I think they're not being completely...
Right. And you know me, I'm a fairly straight up person. I'm not going to comment about that, Homer.
Right. I have a question from Dr. David Ting. The
Yep.
question is, what do you think about the flexure of the mandible? Do you splint or do you avoid splinting between the posterior and anterior areas?
I do splint, and I do think the mandible flexes, and I think the maxilla flexes. And I've restored a couple of cleft palate patients, so I haven't had an issue with mandibular flexion. As long as your prosthesis is passive, you can potentially get away with it. I know there's research about mandibular flexion, that it could be a problem and so on. And I have made prostheses that are divided in the midline. If your patient is symptomatic and they're having pain, something is not fitting right. So mandibular flexion is a thing. Does it make a clinical impact to my everyday practice? Not so much. I mean, I've literally done thousands of these, and I spend a lot of time trying to make sure my prosthesis is passive. If I can try in my titanium bar with one screw, with minimal flexion, and everything is seated, then that's a passive prosthesis.
Okay. So Dr. Danish Barmer has a question. What are your choice of teeth material and prosthesis in patient with initially open bite in the anterior and start with, and less prosthetic space posterior with 4 millimeter bone reduction done, but still abundant bone, had to undergo full mouth implant placement of 6 to 8 teeth on each arch?
That's a good question. I have a case that's somewhat like that, and it's a patient with an anterior open bite who is a tongue thruster, sleep apnea patient, and I'd like to pull that up, if I may, to kind of demonstrate it. So let me just 1 second. I don't know if this completely answers what you're asking, but I think, can you see my slides or not?
Yes.
So here he is, the beginning, tongue thrust, anterior open bite. You can see the Simperio. And the patient wanted to save teeth, and so did I. So in the mandible, we took out incisors, and number 18 in the maxilla, we took out everything. We did 2 implants, 23 and 26, and we did an upper all-on-4. And I didn't close his anterior bite all the way. And I was concerned that if I closed his anterior bite, it would have retruded his tongue back. So here is the provisional. And I'm going to show you some. It's kept the cross bite. I was concerned about neutral zone. Here's a 5-year post-op. So you got to take into account the airway. It's not just about bone reduction and prosthetics. You got to think of the airway and patients talking and not having apnea. I don't know if that case was helpful or not, Homer.
That's beautiful. That's really...
But I did not close down the open bite completely. You can see I left him with some open bite because we were concerned that if we closed it the whole way, it was going to affect phonetics and it was going to make his apnea worse. And in fact, he no longer has sleep apnea because he's lost so much weight.
Great. So another question is from Anonymous, is what about the choice of abutments? Some are using external hex implant and basically making a prosthetic directly to the head of the implant and avoiding and working at the implant level rather than abutment level.
Yeah, so I used to do that when I worked with Nobel, replace select, because you could use a non-engaging abutment and the implants were parallel. So if you're placing parallel implants straight up and down, like we saw in the presentation with the lady with the hybrid with the prosthesis that was poorly fabricated, and you've got parallel implants, it may be possible to do that. I like the idea of using abutments. I learned the hard way with this zygoma case, this poor lady. I did not use multi-unit abutments first go around. I went straight to the fixture here. And every time she had a prosthetic fracture, I had to take this out and get abutments on really, really quick. So from a transmucosal abutment or getting through the gingiva, you got to use multi-unit abutments. This was me being cheap, to be honest with you. This is from 2006. I retreated this patient and I put multi-unit abutments on here so that if she had any kind of acrylic fracture, I didn't have to deal with that problem.
Well, from a biological standpoint, you have to consider where is your point of leakage. If you have leakage at the implant level, that could really affect your bone.
Correct.
Versus when you bring in the, your connection, when you place multi-unit abutments, that's a much more sealed interface between the abutment and the implant.
To be honest with you, for me, for these types of cases, if I could use tissue level Straumann for these cases, I would every day.
Yeah, I agree.
Right?
I agree. So I have another question from Dr. Tahmosevi. The question is, do you use mostly FP3? Do you do any FP1 or 2? I don't know what FP stands for.
It's a classification, I think, from Europe, where they're talking about whether the teeth are resting directly on the, basically an FPD with no gingiva versus no, I do some crown and bridge directly, but I'm not very familiar with that classification, Homer. I know that there was a lecture on Facebook tomorrow from somebody in London and so on. So I use what is indicated for that patient. It's not one size fits all.
I see. So let's see. Another question: do you have any tie-base decementation, and how much of it?
Well, I don't use tie base with these cases, but I have had some issues with tie base because mechanically, when you think about it, it's a very short abutment with a long prosthesis on top. And so I've had a patient that developed a fistula because there was some decementation. So I'm not a huge fan. I like to use multi-unit abutments. Are you talking about tie-base decementation within a zirconia prosthesis?
Well, I imagine when the strictest sense, when you use tie-base, those are for single units. But I would imagine they're talking about the titanium cylinders.
Right, yeah. So I've had some issues where they used a very short coping. I've also had some issues where the coping has de-cemented inside the zirconia prosthesis. And a lot of that is to do with the resin cement and how the coping is treated. Is it sandblasted and so on? So there is some inherent weakness in cementing copings inside of the zirconia prosthesis, but that's how it is. You can't drill all the way through and have a long coping because then the zirconia is going to be weak.
Right. Another question from Dr. Alfonso Pinheiro. Any tips on maintenance?
Yes, that's a very good question. So typically with maintenance, patients should be using a sulca brush. They should be using a superfloss, water pick, seeing the hygienist once or twice a year. And there is actually a kit made by the eponymous Dr. Pinheiro that helps you with hybrid maintenance, but I don't know how to use his kit. You would have to ask him.
Okay. Hopefully he can share that with everybody. Another question from anonymous attendee. Would you use CBCT-based bone reduction guide for implant positioning? Is it better than freehanded surgery? I would imagine basically a stereolithographically produced
Yeah, so we use those, Homer, for atrophic maxilla, where Jeff has to be very, very precise with his initial osteotomy. We will use those. They are screw retained where you're drilling through the buccal cortex. But like anything, if the guide is misfitting or off, you can have an issue. So we are using those for some of these cases, and I will defer surgical questions to surgeons like yourself or Dr. Burstein, because that's not my area of expertise. I think you use what you can where it's indicated.
Right. So I think for me, it's always starts out by having the implants virtually planned in the software. Every time we would plan them digitally for the implants, we may not necessarily use a stereolithographically produced guide.
Right.
Yeah, but I would measure where the head of the implant is going to be, where the platform is going to be versus the relative crest of the bone. That would tell you how much anatomically is required to reduce the bone. But many of the parameters that you described, you cannot digitally produce them. For example, relative to the smile, where should the resection be relative to the smile? At the moment, we don't have any digital workflow to determine that. So you have to assess that in an analog world.
Yeah, you also have to have photos, Homer. So for these cases where a patient has a high smile line, I am taking a pre-op photo. Like I said, I'm printing it. I'm putting it in the surgeon's office or in the OR so that he has a real good idea of what this patient looked like with a high smile line and repose and when they're not numb. And so it's very, very important that whoever's doing the surgery and the prosthodontist are sort of well aligned so they understand what the end goals are. Are you able to see these slides?
Once you put it in presentation mode. Right now, no.
Okay, hold on. This is to go back to somebody who was asking about FP1 and FP3 and sorry. Okay, let's look now. So this is the sort of diagnostics you need to do. If you don't have enough vertical space, you have to plan this case as a crown and bridge case. So the prosthetic design, the maintenance, and the complications. Here is a case that was done in Argentina by a colleague of mine. I actually referred the patient there. This is by Dr. Cagnoni in Buenos Aires. I referred the patient there. He's had implants placed and immediate extractions for a crown and bridge case. And here's a surgical guide showing me that we're going to be able to be screw retained posteriorly in number 5, cement retained in 6, cement retained in 8, possibly cement or screwable in 9 and 11. And then again, so you've got to have really, really clear communication. So it's not always hybrids. And there are certain patients, here's another case, that aren't candidates for an all-on-4. Let me show you this case. So this is a dolichocephalic patient, super eruption. He's a big guy, he's a bodybuilder, he's a plumber, significant wear, super eruption of mandibular anteriors, collapsed occlusion. I've opened his vertical dimension up, and I'm restoring his maxillary arch with crown and bridge on 4 and 5, 12 and 13. We're extracting all of these. He also has an impacted canine. So now he's got a 3-implant FPD. He's a bruxer. He didn't care about having gold. And in the mandible, pretty simple. So not everybody's a candidate for an all-on-4. I want to stress that point. There are certain materials that are very, very durable. You could do this as PFM with metal occlusals and porcelain facings. You could do whatever you want, but you got to understand what your goals are. If he's worn down his natural teeth, like so, what's he going to do to acrylic? No chance. What's he going to do to zirconia? So in this instance, proprioception is an important thing. I want this patient to save as many teeth as he can. If nothing else, you can see we've taken out 22 through 27, placed an implant in 22, implant in 27. If nothing else, the teeth give him an idea of how hard he's biting, where he's biting, stereognosis, proprioception versus osteoperception. So not everybody gets this treatment. You got to use your brain, right?
That's right. So just want to make an announcement about next week's webinar. At the same time is Dr. Fernando Rojas Vizcaya, who will talk about the digital and analog workflow of how to integrate the patient's face and smile into the planning. So I think that would also go very well with what Dr. El-Ebrashi presented today. One more question, I think a follow-up question by Dr. Tamasebi about the titanium cylinders coming off within zirconia prosthesis. Do you have any tips about cementing them? Do you use any kind of an etchant on the titanium cylinders or anything like that?
That's a good question, Homer. I don't actually take care of that myself. If something is coming off, I'm having my lab take care of that. I don't cement these intraorally. I had a general dentist contact me in Bend. One of my patients got hit in the face. The bridge came out. It was a zirconia bridge, came out, and the copings were all in the mouth. There was no fracture or anything, and he cemented them one at a time using C and B Metabond. It's a pretty technique sensitive thing.
Great. Well, Sam, you've been very generous with your time and with sharing the information. We really appreciate it. You obviously are a beginner at this. You only have 300 to 400 of these zirconia cases.
Yeah, I'm learning every day, Homer.
So really appreciate it. It's great to see you healthy. Be well. And to all the colleagues who were able to join us today, I really appreciate this opportunity to connect with all of you. So we are scheduled to conduct a webinar next week, same time, Tuesday, 1 p.m. Pacific time with Dr. Fernando Rojas Vizcaya. We also have hands-on online workshops next week starting on Wednesday and Thursday. So we still have a couple of more spots available for that. We actually don't have so many positions for that, but if you're interested, I would recommend you to go to our website, learnvista.com. We're also going to be hosting a webinar in the next few days on teledentistry. We're working with one of the colleagues who developed dental chat. This is a really interesting, and we incorporated that into my own website, and we're getting a lot of people expressing interest with that. So we'll make the announcement to you shortly. So great to see you, Sam. Thank you very much for all.
Appreciate it. Thank you. Be safe. Bye, Homer. Thank you.
Well.
Bye-bye.
Take care.